cardiac pacemakers, and cerebral physiology. User question: can altered cardiac output from pacemaker settings affect cerebral blood flow and metabolism? AI DeepSeek answer: yes. Altered cardiac output resulting from pacemaker settings can significantly affect cerebral blood flow, CBF, and, consequently, cerebral metabolism. This relationship is a key consideration in clinical cardiology and neurology, particularly in patients with pre-existing cerebrovascular disease or heart failure. The physiological link: cardiac output and cerebral perfusion. The brain is a highly metabolically active organ with high oxygen demand. It relies on a continuous supply of blood flow to function properly. Under normal conditions, CBF is tightly regulated by a process known as cerebral autoregulation, which maintains a relatively constant flow across a wide range of systemic blood pressures, typically 60-150 mmHg mean arterial pressure. Cardiac output, CO, is a primary determinant of mean arterial pressure, MAP, which is the driving force for cerebral perfusion. The relationship is defined as MAP equals COA, systemic vascular resistance, SVR. Therefore, a significant reduction in CO can lead to a decrease in MAP. If the drop in MAP is substantial enough to fall below the lower limit of cerebral autoregulation, CBF becomes pressure passive and begins to decline. This reduction in CBF can impair the delivery of oxygen and glucose, potentially affecting cerebral metabolism and cognitive function. Evidence from pacemaker studies. Pacemakers can alter cardiac output primarily through their effect on heart rate and atrioventricular AV synchrony. 1. The role of atrioventricular AV synchrony. Loss of AV synchrony, as seen in single-chamber ventricular pacing (VVI) mode, can reduce cardiac output by 15 to 25% compared to physiological atrial-based pacing (AI) or DDD mode. The atrial kick contributes significantly to ventricular filling, especially in patients with diastolic dysfunction. Key evidence. A study by Sulk et al. 1992 demonstrated that VVI pacing was associated with a higher incidence of cerebral hypoperfusion and pacemaker syndrome, which includes symptoms like dizziness, confusion, and fatigue euro, symptoms often linked to reduced CBF. Research using transcranial Doppler TCD has shown that DDD pacing results in higher middle cerebral artery flow velocities, a surrogate for CBF, compared to VVI pacing, directly linking improved hemodynamics from AV synchrony to better cerebral perfusion. 2.2. The role of pacing rate and site. Excessively high or low pacing rates can also impact CO. A rate that is too low may not provide adequate output, while a rate that is too high can not only reduce diastolic filling time, but also potentially induce tachycardiomyopathy. Key evidence. Studies on rate-responsive pacing have shown that optimizing the heart rate to match metabolic demand can improve exercise capacity and, by extension, prevent a drop in CO and CBF during physical activity. His bundle pacing or left bundle branch area pacing, which provide more physiological ventricular activation, have been shown to improve cardiac output and hemodynamics compared to traditional right ventricular apical pacing. This superior hemodynamic profile is presumed to benefit cerebral perfusion, though more direct CBF studies are ongoing. 3. Impact on cerebral metabolism and cognitive function. Chronic reductions in CBF can lead to cerebral hypoperfusion, which is a proposed mechanism for vascular cognitive impairment and dementia. Key evidence. Long-term follow-up studies, such as those from the MOST mode selection trial, found that patients with frequent ventricular pacing had a higher incidence of atrial fibrillation and heart failure euro, both risk factors for stroke and cognitive decline. 4. While direct, long-term metabolic studies, e.g., using PET scans, in paced patients are limited, the logical pathophysiological pathway is clear. Reduced COA, reduced CBF-A, reduced delivery of oxygen/glucose-A, compromised cerebral metabolism, and potential neuronal injury over time. Conclusion: the hemodynamic settings of a cardiac pacemaker are not isolated to the heart. Altered cardiac output, particularly from loss of AV synchrony or suboptimal rate response, can directly impact cerebral blood flow. This can manifest acutely as symptoms of pacemaker syndrome, e.g., lightheadedness, and may contribute to long-term risks of cerebrovascular events and cognitive decline. Therefore, optimizing pacemaker settings to maximize cardiac output and maintain physiological rhythm is a critical goal not only for cardiac health, but also for cerebral well-being.